Dr. Cionni, Dr. Solomon, and Dr. Osher left their respective residencies, you can bet that the one case each was not eager to encounter was the case with severe zonular damage. It didn't matter if the zonnular lysis was secondary to trauma or was associated with a systemic disease, such as Marfan syndrome. Loose zonules, lens subluxation, and phacodenesis meant big trouble. In the mid-1980s, Dr. Robert Osher presented a controversial paper at the ASCRS, challenging the accepted surgical dogma by showing the results of phacoemulsification in a series of patients with zonular dialysis. Using his technique of slow-motion phaco, where all parameters were markedly reduced, an endocapsular procedure through a mini rhexis would preserve the capsule of the loose lens. Subsequent extension of the rhexis to allow implantation of a single-piece lens into the bag was occasionally supplemented by suturing the trailing haptic for security. The next step in the evolutionary process was the introduction of the Morcher endocapsular ring by Drs. Legler and Witschel of Germany. In 1993, and then again in 1995, Drs. Cionni and Osher published their work on stabilizing the capsular bag even in the most difficult cases with extensive zonular dialysis. The idea of suturing the haptic through the bag and around the anterior capsule produced a more stable lens with a characteristic peaking of the anterior capsule. The next development was Dr. Osher's idea of the synthetic zonule in 1996, in which suturing the endocapsular ring to the sclera would allow recentration and stabilization of the loose, decentered capsular bag. The drawback was that delicate suturing of the endocapsular ring through the equatorial bag was required, and the integrity of the capsule was compromised. The final step in our search for the solution to severe zonular damage was developed by Dr. Robert Cionni, a modified endocapsular ring. Also manufactured by Morcher, it consists of a similar open, flexible PMMA filament with eyelets at the ends. Joined to the ring is a PMMA fixation element or hook, which extends centrally and then courses anteriorly into a second plane where it turns peripherally. At the free end of the hook is an eyelet, which comes to rest on the anterior surface of the anterior capsular rim. This eyelet is used to secure a double-armed proline suture, which is then passed through the ciliary sulcus and scleral wall, achieving permanent centration and stabilization of the capsular bag without violating its integrity. Let's examine the stabilizing effect of the Cionni ring by viewing these Miyake preparations. The superior zonules have been lysed, the capsular rhexis completed, and the modified ring placed into the capsular bag. On the left side, the ring has not yet been sutured to the scleral wall, while on the right, the suture has been secured. Notice the mobility of the capsular bag during the phacoemulsification on the left, while the capsular bag is more stable on the right. The same enhanced stability is apparent during the cortical removal. It should be pointed out that the anterior capsule was inadvertently hung up on the eyelet of the fixation hook unbeknownst to this first-time surgeon. Insertion and rotation of the intraocular lens provides convincing evidence for the increased stability when the ring is sutured. Now let's observe the surgical technique in several patients. This 37-year-old man had bilateral subluxed lenses, bilateral iris and chorioretinal colobomata, and yellow nuclear sclerotic cataracts consistent with 2200 vision. After appropriate informed consent and removal of the nucleus by slow-motion phacoemulsification, a double-armed 10-0 proline suture is passed through the fixation eyelet, and each of the CIF4 needles is directed through the pupil, over the anterior capsule, through the ciliary sulcus, exiting the eye over the area of zonular weakness beneath the scleral flap. After the capsular bag is inflated with Helon GV, the modified endocapsular ring is ushered into the bag. Notice how the capsular bag centers and stabilizes as the sutures are tightened and tied. An acrylic lens is safely implanted into the capsular bag and the procedure is completed in a routine fashion. On the following day, the uncorrected vision measures 20/50 and the intraocular lens appears centered within a stable capsular bag. This 47-year-old woman with Marfan syndrome had a visual acuity reduced to 20/160, consistent with mature nuclear sclerosis and dense posterior subcapsular opacification. The cataractus lens was decentered supratemporally with thin, stretched zonules between 5 and 8 o'clock, giving rise to impressive phacodenesis. In the operating room, after the cataract was removed by slow-motion phaco, the double-arm 10-0 Prolene suture is passed through the eyelet of the ring, and the needles are directed through the ciliary sulcus, exiting the eye over the area of zonular weakness. The endocapsular ring is inserted into the capsular bag, and the fixation element, which is over the anterior capsule, is dialed toward the area of zonular weakness using a Sinskey hook and gentle tension on the sutures. The sutures are tightened, tied, and rotated until the knot is buried. An intraocular lens is then placed into the capsular bag, and the procedure is finished without difficulty. On the first postoperative day, the uncorrected visual acuity measures 20/25, and the lens is well centered without pseudophacodenesis, confirming the stability of the capsular bag. A 34-year-old woman had a history of severe blunt trauma to her left eye, which eventually reduced the vision to 2100, consistent with an advanced cortical cataract. The zonules were absent for 5 clock hours between 8 and 1 o'clock. The lens showed infratemporal decentration, and vitreous was present in the anterior chamber. After the nucleus was removed and a dry vitrectomy was performed, the eyelet is sutured through the ciliary sulcus and the ring is inserted, facilitating the cortical removal and cleaning of the posterior capsule. The intraocular lens was placed into the capsular bag and it centered spontaneously. At the 6-week postoperative visit, the intraocular lens appears centered and stable. A 64-year-old man had a traumatic cataract complicated by 180 degrees of zonular dialysis. The acuity was reduced to 2200 and the cataractus lens was displaced forward, shallowing the anterior chamber, resulting in an elevated intraocular pressure. The lens was so loose that it had to be stabilized with an iris hook during the capsulorhexis. The modified ring was placed into the capsular bag prior to completing the phaco, stabilizing the lens for the emulsification. Once the ring was secured to the scleral wall, the procedure became routine. A single-piece intraocular lens was placed into the capsular bag where it centered spontaneously. During the first week following surgery, the vision improved to 20/40 and the intraocular pressure was normal. The lens and capsular bag appeared centered and stable. While it has taken more than a decade, we now have laboratory and clinical evidence that our goal of developing a surgical technique for severely damaged zonules has been achieved. We have previously learned that slow-motion phacoemulsification can safely remove the contents of the loose lens. Now, we've shown that the Cionni modification of the endocapsular ring allows the loose eccentric capsule to be recentered and secured, achieving safe endocapsular implantation and long-term stability of the capsular bag.